Okay, I want to thank everyone for coming to this lecture tonight. Masks, mutations, and vaccines, what's next with COVID-19? I am Margaret Winter and have been organizing the non-sailing speaker series at the Royal Canadian Yacht Club for 9 years and love giving back to my community, connecting people and sharing interesting and valuable information. Tonight, Lionel Mandel has joined us to give this talk on COVID-19. Dr. Mandel is Professor Emeritus of Medicine at McMaster University and former president of the Canadian Infectious Diseases Society. He's been invited to 60 countries to speak and consult and chaired the committees for the national guidelines for pneumonia for the US and Canada. For his contributions to infectious diseases, he was made an honorary fellow of the Royal College of Physicians, London, and last October was invited to give the annual Zinner Lecture at Harvard, describing his latest work. He is currently the author of the pneumonia chapter of a textbook co-edited by Dr. Anthony Fauci. Dr. Mandel currently sits on 8 international monitoring boards assessing the safety and efficacy of antiviral COVID drugs under development. Dr. Mandel, over to you.
Thanks very much. Can you hear me okay?
Yes.
Okay. Well, thank you very much for setting this up, and good evening to everyone. I want to thank you for giving me the opportunity to be able to speak to you and to thank you for listening. I'm sorry this is by Zoom, and hopefully we'll be seeing each other soon on the island. And I also want to start as well by thanking my colleague Teal Alangasinga, who helped me with all these slides and had to listen to every iteration of this. So thank you, Teal. Okay, this it's not advancing. Oh, okay. All right. I wanted to use Margaret. Is there any way getting rid of the videos on the side so we can see the whole slide?
Full screen. Is that better?
Yeah. Okay, can you hear me?
Yes.
Okay, so I wanted to start this with a quote from Marie Curie, who shattered the glass ceiling in the early 1900s. She won 2 Nobel Prizes in physics and in chemistry. And she said, now is the time to understand more so that we may fear less. I know that there's a lot of anxiety and fear out there, and I think that the best way to diminish fear and to deal with it is to understand your enemy. I know that the the group at the RCYC is a sophisticated one. I know this from talking to people and the questions they've asked. I'm going to be going through a lot of material, but it's not difficult. And hopefully it'll give you enough information so that you'll be able to understand and interpret what you hear over the coming weeks and months, because some of it can be a bit confusing. Now, for those of you who remember being in a restaurant, you'll recall that in some restaurants, they'll have a board up with today's menu and they'll list the specials. So the specials today are for issues and information. We're completely sold out of any definitive answers. So you'll have to go elsewhere if you want definitive answers. Now, one of the things I want to stress right at the start is about the information. And let me first begin by giving you some background on myself and where I'm coming from with this. I'm from Canada. I did, contrary to what my kids say, I didn't just work 2 summers in a drugstore. I went to medical school, then went to the US for training in internal medicine and infectious disease, and came back and worked full time at the university. So my office was in the hospital itself, and I and my colleagues would see patients strictly in the hospital on the wards or the intensive care unit. And in parallel with that, we would do research. So we would take questions from the patient to the lab and from the lab back to the patient. And that led to my involvement with drug development and interaction with some really fantastic people. So the perspective that I was able to gain through this was not just from a practical and pragmatic aspect dealing with patients, but also from an academic aspect and dealing with government issues, et cetera, bureaucratic views. So I've seen the three sides of the triangle. What I want to caution you about is when you hear things about scientific data, you'll hear things that are word of mouth. It really depends whose mouth it's coming from. So be very careful who you're listening to. You'll hear things that are press releases, and that's what they're worth. They're press releases. And we can talk more about that later, but the data don't really start to gain gravitas until you start getting into the journals. And even within journals, there are non-peer reviewed and peer reviewed. Non-peer reviewed means that you just submit it and they publish it and nobody has critically looked at it. But even within the peer reviewed journals, you have to be careful. There's a thing that's called the impact factor. And the higher the factor, the better it is. So the New England Journal of Medicine has the highest impact factor of any journal in medicine or science. It's 74.7. At the other end, where a lot of this stuff is coming out on, it's an on-site journal called PLOS. The impact factor is 2.7. Now, again, to put this in perspective, Nature, which is the journal that Watson and Crick published their Nobel-winning paper on DNA, has an impact factor of 42.8. So even if someone tells you it's from a peer-reviewed journal, it may not necessarily be a good one. So be very careful of what you believe when you're hearing things. Now, the topics I want to touch on over the course of the next few minutes will be the virus itself, mutations, the disease, masks and mask-related issues, treatment, and vaccines. Now, in terms of the virus, I think you've all seen these pictures before. This is the SARS-CoV-2 virus, and you can see the little crown around it with the these little projections. That's why it's called the coronavirus. This is the way the virus actually really looks like. There's a membrane around it, or an envelope, and inside is the genetic material for that virus. And if you talk about the genetic material of something like a virus or a person or a dog, you refer to it as the dog genome or the viral genome or the human genome. And Macfarlane Burnet was a Nobel laureate a number of years ago who referred to viruses as bad news wrapped in protein. And that's probably the best description ever of a virus. The thing that's going to come up time and again during this talk will be these little spikes that you can see here. These are these spike proteins, and these are what the virus uses to hook on to the host. Now, in terms of the interaction, you can see that here comes the virus, and this is a patient's cell. Let's say it's in your nose or in your lung or whatever. It's just like a boat coming into a harbor. It has to find a slip or a mooring ball before it can hook on. Otherwise, it's just floating around. So it uses these spikes to hook on. The mooring ball here would be this, it's called the ACE2 receptor that sits on the cell membrane. So everybody watching tonight has these ACE2 receptors on your cells, and these viruses can come along and hook onto it. The obvious thing would be if you could produce an antibody or something that would block this or interfere with this. And that's where the vaccines come into play. This is just to show you a prettier picture. Oops. This is the, you can see the spike blown up and hooking on to the ACE2 receptor in blue. Now, when the virus actually attaches to a cell, it sort of injects its contents inside the human cell, and a bacteria can reproduce on its own, but viruses are incapable of doing that. So they have to hijack machinery from the human cell. And so your own human cells produce more virus. And as they produce, the numbers go up and they blow through the cell. Now, we all tend to attribute human qualities or qualities to animals or viruses or whatever. And we talk about the virus outsmarting us. The virus doesn't outsmart us or outthink us. And I just wanted to use this slide to illustrate this. If we look at humans on the planet, the numbers are 7.6 billion. If we look at SARS-CoV-2 virus over the last year, there have been 10,000 trillion, 10 to the 16th. If we look at brains in humans, it's about 250 million tons of brains. There isn't one single brain or one single brain cell with SARS-CoV-2, but they continue to outsmart us. So how does this happen? Well, it happens through mutations. And VOC stands for variant of concern. This is pure Darwinism at its best. It's really as basic and as existential as it gets for the virus. It's trying to survive and it's doing whatever it can. And if it has to shift around to evade us, it will do that. So think of the viral genome as a set of building instructions. So it's like if you go to IKEA to buy a bed and it gives you a set of instructions, you put the bed together. If there's a mistake in those instructions, your bed isn't going to look the way it's supposed to. So that's exactly what happens here. A mutation is an alteration in those instructions, and a change in instructions can lead to a change in the virus. Now, how do these mutations occur? Well, they can occur, mutations can occur by like exposure to X-rays or radiation or smoking. Viruses stopped smoking a long time ago. So the main way it happens is through what's called recombination or copy errors. Recombination is very easy to understand. It happens a lot with influenza, a little less so with coronaviruses. But you can see here that on the left, you could have a virus in a duck or a bird, and then you could also have a virus in a human, and those viruses happen to mix in a pig, and the genetic material interchanges, and now all of a sudden you've got a virus that goes out into the human population that nobody recognizes, and so now you've got a problem. So part of the reason that sometimes outbreaks, particularly of influenza, have come from China is it's thought to be because China has the largest grouping of animals and humans in close contact. I mean, this is a lot less likely to occur in South Dakota or Alberta, for example. Now, the other way is by what's called copying errors. So again, we're looking at the virus again, and this is the RNA of the virus that we're pulling out here. And just to take you back to university or whatever, the DNA is on the right, the classic double strands, and the RNA is on the left here. It's a single-stranded nucleic acid. And there are DNA viruses, but coronavirus happens to be an RNA virus. So it has 4 different building blocks on it called cytosine, uracil, adenine, and guanine. And the point of this is that the order in which these line up acts as a code. So AUC means something different than GAU, okay? Now, it's one thing to say, look, you've got 4 blocks, just put them in this order, and that's fine. Most of us could probably do that, 2, 3, 4 times. But if you said to somebody, okay, do it 100 billion times now, you're going to get a mistake. And mutations happen all the time in viruses, but most of them don't mean anything. So this is just a simple representation. For example, mutation A may result in no change at all to the protein. The mutation simply didn't matter. Mutation B might end up producing the protein that's now useless. The bad news is for us is that if mutation C happens and you get a new and improved virus, you've got a problem. And that's what's starting to happen in the community now with UK and et cetera mutants. Now, the other problem is it depends where the mutation happens. If the mutation is happening in this spike protein, which is the hook, that's not great. And what makes it even less great is that that's where the antibodies and the vaccines are trying to work. So at exactly the site where our vaccines and antibodies are supposed to be working, changes are starting to happen. So that raises this whole question of, are the vaccines and will previous immunity, if you had COVID before, provide protection? Okay, this is an example just to illustrate this. Here's a climber going up the side of a mountain, and that's exactly what the virus is doing. It's hooking on to us, and you can imagine that if this climber had a mutation that gave him stronger, longer fingers that were stronger or better upper arm strength, he'd be able to hold on better and climb better and faster. So he'd be a better climber. And that's exactly what happens with the virus. You could also argue if he had a mutation that gave him a better brain, he wouldn't be in this position in the first place. But it's pretty clear how these mutations can happen to give a selective advantage. Now, as you can guess, if the mutation enhances the ability to attach, that is going to translate into increased transmissibility. And then this raises another issue. There's talk about whether a virus is more virulent or not. And some of them could become more aggressive, but even if it's not more aggressive, just the fact that you've got more people infected, even if only a small percent are dying, you're going to end up with more people dying. So the death rate will go up with increased transmissibility. It'll go up more if there's increased virulence as well. Now, back to the schematics, just again, here's the coronavirus, and inside, just imagine the genome, and here's the D614G mutation. And this is what I want to use to explain. Here's on the left, the D614 coronavirus. That was the virus that was predominant in Europe last year, in January, February of 2020. And it was a reasonable virus. It could hook on pretty well and reproduce, and you got some virus out of it and obviously infection. It then mutated though, and you got the D614G. And that unfortunately hooked on a lot better, so it was more transmissible. And you can see the difference here. A lot more virus got produced. So if we look at this in terms of a timeline, this is from January 2020 coming out to May 2020. Initially, it was all D614. Then this new virus comes along that hooks on better, and it just completely replaces it. And that's the concern that might happen with new mutations that are occurring now. And some of them have started to become dominant in different countries. The UK variant became dominant in Europe, in Britain, for example, within several months. The California variant has started to become dominant within several months as well. This is where I think it gets really fascinating. That spike that I was talking about, the spike protein, just imagine this as the spike protein. And you can imagine if this was the hand of the mountain climber, it'd be pretty hard to hold on to anything. It's like having a closed fist. But if you started to open that fist up, and this is exactly what happens with the spike-glycoprotein with mutations. Oops. It opens up a bit there, then here it opens up 2 parts, and then now 3 parts open up. So instead of having like a blunt hook, you've got one that now has 3 prongs on it. And geez, I don't know why that's happening. The likelihood of infection is going up as that happens. This is another representation of this, and you can see the red coming down is the spike glycoprotein from the virus, and you can see 3 prongs opening, and it's about to hook on to the blue ACE2 receptor. So the mutations that allow more openings of that hook lead to more transmissibility, which leads to more cases, which leads to more deaths. Now, everybody talked about R naught last year, so it's not as hot a topic anymore, but it's still extremely important. The R naught is the reproduction number. So an R naught of 1 means that one person gives it to one other person. If the R naught is 3, one person gives it to 3 people. So if the R naught stays at 1, you're going to stay, your numbers won't change. If it drops to say 0.8, your numbers in the community will drop. If it goes above 1, they start to increase. So here's the really bad news. This is a model, and as Tony Fauci says, a model is just a model, and they don't always predict what's going to happen. But the vertical axis is number of cases, and this is looking at cases in Ontario with the variant. The horizontal axis goes from last October to mid-March of this year. And the pink here is what would happen if there were no variants. This red is what would happen if you had variants, and you can see the difference. So that's what the concern is right now, that we may be starting to see a situation where these variants are taking over. Now, the control measures that I'm just going to spend one slide on this, the province puts into effect. It's not just an arbitrary thing. There are, in fact, categories: gray, red, orange, yellow, green, and they depend on certain variables, and there are cutoff points for each of these. So the variables they look at would be the incidence or number of new cases, what percent positive. So for example, if you had 2% of your tests are positive, that's a lot better than if suddenly 5% were positive. And we're now getting up to that range. I think the latest was about 4.8%. They look at the R naught, and we're above 1. They look at the number of outbreaks and the size of outbreaks. And one of the key things is trying to protect the hospitals and the ICUs. So we're trying to protect individuals, societies, and the sort of jewel in the crown, supposedly, is the hospitals and ICUs. Now, the obvious concerns with these mutations are, will they become dominant? Will they drive a new wave? I think we know the answers to this. And then the really critical question is, will they decrease the effect of antibodies and vaccines? And the short answer is they do in some cases and to some extent. Okay, so here I know we're not supposed to use name countries, but if we use numbers, it just gets too complicated. Under mutation, I've got the UK mutation, the South African, and the Brazil mutation. And then across the top is transmission, virulence, and evasion of antibodies or vaccines. So all 3 of these variants, UK, South Africa, and Brazil, and they're all in Ontario, primarily UK, increased transmissibility, no question. In terms of virulence, it's possible with UK, those data are hard to interpret. In terms of evasion, it looks like the vaccines we currently have work against the UK variant. It's just not known for South Africa and Brazil. So definitely an increase in transmissibility, possibly an increase in virulence, and the jury's out still on the evasion issue. But not to be outdone, North America on its own, the US has come up with its own variants. New York City has a variant that is of concern very recently, 65% of the isolates, of the tests in New York City were positive for variants, not the regular virus. And 45% of the total were this new New York City variant. In California, there are two variants. In December, they represented about 5% of the isolates. They are now about 50% of the positives. So in terms of increased transmissibility, it's not absolutely certain, but it looks like it might be the case. And they're not quite certain about evasion. But again, this is being followed, as you can guess, very closely. And again, there are many other variants. There's now a Brazil 2 variant, but a lot of them will just simply die off. Some of them, unfortunately, won't. The other thing to keep in mind, and this is what's critical, is that the ability to form mutations of consequence will vary with two things. The more time you give that virus, it more it reproduces, the more chance for a mistake to happen that will help the virus. The other thing is the more cases, so the more people it can reproduce in, because it cannot reproduce on its own, the more chance of a mutation happening. So what's absolutely critical to control this is to reduce the spread, and to do that by the standard methods like masks and distancing, which work, and to, at the same time that we're keeping the numbers down, to vaccinate as quickly as we possibly can. Okay, let's look at the disease quickly. You've heard descriptions of the disease, and it seems to affect every organ system, and it does. And this is the reason. The hookup for it, the virus can come in, has to hook up to this ACE2 receptor, is everywhere in the body. It's not just in the lung. So when the virus comes in, it can hook on to ACE2s in the lung, the kidneys, the brain, the heart, blood vessels, etc. And that's why you have people, you might have somebody who never coughs once but gets a stroke. You might have someone else who has some diarrhea but nothing else. So it really can vary depending on where the predominance of injury is. So again, it can be brain, heart, lung, etc. So that's also what makes it somewhat confusing and difficult, especially to treat. Now, this is, I think, a very important slide. The vertical axis is severity of illness, and the horizontal axis is time. Now, early on, and this has huge impact in terms of treatment, and I'll expand on that a bit later. Initially, all the damage is from the virus. So you've got a perfectly healthy person, the virus comes in, starts causing problems, and you go from being asymptomatic to developing some symptoms. Now you've triggered the immune response. The immune response starts to kick in, and your severity score starts to go up. And if the immune response isn't controlled, you can end up with real problems. So ideally, if you had treatment early on, you would treat the virus. Later on, you would treat the immune response. Now, at the extreme end is what's called the cytokine storm, and I'm sure you've all heard that term. To use an example of a fire, if you imagine that your body is a house and the virus is a fire, you've got a fire occurring in the house, and then the sprinkler system comes on, which is great. The sprinkler system is the immune system. It puts out the fire. That's wonderful. The problem is the sprinkler system doesn't turn on, and in fact, it starts pouring more and more water. It ends up flooding the house and killing everybody in it. That's what the cytokine storm does. Now, in terms of the spectrum of disease, I think you all know, certainly you don't need this Venn diagram to show it. It can go from one extreme asymptomatic to the other, which is symptomatic. Everybody knows to avoid someone who's coughing or vomiting. The real risk is in these patients here who are asymptomatic and may be transmitting it. And just a few days before you become symptomatic is when you have the highest viral load. So you may get some virus on you and you're asymptomatic. It's all a numbers game. But here the numbers are small. But just a couple of days before you get sick, the numbers shoot up. And that's when you're a problem, because nobody knows that you're sick. They might be close to you. They get high loads of virus and then they can become sick. Now, it ranges a lot from relatively mild. And the good news is, and there is a lot of good news in this, that a lot of people do fine. And then, of course, there's the other extreme. It's much, much smaller numbers, but it's terrible when it happens. In terms of classification of the symptoms, basically it's broken down as you'd expect: mild to moderate, severe, or critical. Mild to moderate basically means that there is no pneumonia or just a mild pneumonia. The magic number here is 94. So we tell a lot of the patients to buy these little pulse oximeters. It looks like an old-fashioned clothes peg. Put it on the end of your finger. You can buy it for about $40 or $50 in the drugstore, and it measures your O2 sat. So as long as it's over 94, you're fine. Severe means you've got shortness of breath and your O2 sat's below 94. And critical is exactly what you'd expect: your respiratory failure or shock or multi-organ failure. Now, again, if you look at this pyramid, it's a bit loose with the figures, but the good news is that here it says 80%, at least 85 and often 90% of the patients do not need to go into the hospital. And in Canada overall, it's about 7% get admitted to hospital. So that's the good news. Unfortunately, there is a small number that get admitted to hospital and then a smaller number go to the ICU. All right, I think a term you've probably all heard is the long haulers. This is a social media term. There are other terms that are being used, like the post-COVID syndrome, and there are about 10 other long names for it. But basically, long haulers probably says it best. It's people who got COVID and they seem to have persistent symptoms or organ dysfunction. The problem is that there are really limited data on the prevalence of this, so it's hard to know exactly how many cases are out there. We don't have a defined duration yet, but it seems to be narrowing down to about 12 weeks. It's not clear when it happens what the cause is. Is it low-grade viral reproduction? Is it an inflammatory response? And how best to treat it? And part of the problem is there's no case definition. So, for example, a case definition would be if you said, okay, a long hauler is someone with a positive lab diagnosis by PCR of the virus who has any two of the following 12 symptoms: shortness of breath, fatigue, loss of memory, etc. Then you can start really defining what you're dealing with. But as of now, there is no case definition. The most common persistent symptoms that you hear about are things like fatigue, shortness of breath, chest pain, cough, and cognitive defects like brain fog or loss of memory. And when you look at some of these, the percentage of patients, there's quite a range in the middle column, and then duration in months on the right. Fatigue is by far the most common. It affects up to 80% of the patients. Shortness of breath up to about 70%. Cough, anxiety, and drop in memory. But if you think about everybody you know, certainly just about everyone I know who has not had COVID, if I went to them now and said, are you more anxious than usual? They would say, yes. Are you more depressed? Yes. Is your memory down? Yes. Are you tired? Yes. So you can see where the problem starts to come in. So until we get a case definition, it's going to be difficult to sort this out. Okay, masks. There's been a lot of talk about this, and if you heard yesterday or something, Austria and Germany came out with a mandate that you have to wear N95s. I don't know if any of you have worn N95s. It's a bit like having a root canal. It's awful. First of all, they have to fit properly, but they aren't needed outside of medical care. So what's really important is, first of all, you have to understand why you're wearing a mask. there's two things. Most important is source control. You are trying to prevent someone who has the virus from spreading it. That's the most important reason for wearing a mask, because if they have it, the virus, and they're coughing or breathing hard or whatever, the mask will catch the large droplets that carry the high viral loads before it can break down into smaller droplets that are easier to inhale. It also, though, serves a protective effect as well for the other person wearing the mask. So if two people are wearing a mask, you can see that there's even better effect. The most important things, forgetting about N95 for now, is that they're worn consistently and appropriately, that it conforms to your face without gaps, so that just wearing an N95 that doesn't fit properly is useless, or not useless, but it's not great. A lot of the masks, the good ones, will have a flexible nose bridge with a little wire to help you improve the fit. And it has to be the appropriate thickness. So the standard now is, the recommendation ideally is that if it's a cloth mask, 3 layers with a middle non-woven layer. I think generally I've spoken to a colleague who is one of the world experts in masks and WHO advisor, and he said, absolutely not. Do not wear an N95 unless you're dealing with patients in special situations. That a surgical mask is fine, or a cloth mask. The question of 2 masks we can talk about separately, but other things though, like scarves, bandanas, face shields, gaiters by themselves are not appropriate. Okay, now let's look at vaccines versus treatment. The purpose of a vaccine is to prevent the disease and to prep the immunity, so when your immune system does see the virus down the road, it knows how to react. It's like showing someone a picture of a dangerous person in the community. When you see them, you'll know to avoid them or how to deal with them. Treatment is when you're actually dealing with the disease and having to modulate the immunity and cut the viral load. So the vaccine stuff has been absolutely fantastic. The scientists at the NIH on January 10th of last year were given the gene sequence from the Chinese scientists, and 11 months and 1 day later, on December 11th, 2020, they had a vaccine. Normally that would take 10 to 15 years. It was absolutely spectacular. The drug stuff, unfortunately, the stuff I'm involved with has been much, much slower and nowhere near as successful, unfortunately. Now, just to explain this, the difference and why there is such a difference in the outcomes with vaccine versus treatment. If you said to somebody, I want you to figure out how to fireproof a house, you can see that you'd have to work very hard to define a chemical that is going to protect against fire. So first, you'd have to develop the chemical, you'd have to figure out what concentration it should be in, how to apply it, how the person should be trained to do it. Whereas treatment is quite different. Treatment is where they say, look, fireproofing didn't work, the house is now on fire, the roof's caved in, come and deal with it. So you can see that vaccine or prevention versus treatment and dealing with the disease are 2 completely different things. Now, in terms of treatment, I just want to tell you a little bit about how the treatment research and development works. And this, I would suspect, is very similar for vaccines. But it's happened to me a number of times where friends or whatever, very well-meaning, have said to me, now you just go up into your study and you just solve this. And I thought, okay. So I've sent to a number of people emails saying, look, thanks for your note, but I want you to know my schedule. Monday nights, I solve world peace. Tuesday nights, I cure cancer. Wednesday nights, I reserve for curing pandemics. It's not like you see in the movies. It's not a lone doctor or scientist having a eureka moment. What it is is thousands of scientists and physician scientists working together in the laboratory and at the bedside, trying to develop these things, doing the clinical trials, and then getting the data together. And these clinical trials are huge efforts. An average clinical trial for an antibacterial, for example, could cost 150 million. And the cost to develop an antibacterial drug from start to finish on average is 1.3 billion. So it's a lot of money and a lot of effort. And my situation now is I sit on these monitoring boards where all the data from the trials are filtered down, and then they're given to a committee of, it varies, but either 4 to 5 of us, and we go through the data, and it's at set time points. So for those of you who worried about vaccine safety, don't. I mean, people have gone through the data with a fine tooth comb. I spent this weekend looking at 650 pages of data for a 2-hour call last night, and that was just in the early stages of a study. So the scientists and the drug companies are exceptionally careful, trying to make sure there's safety and efficacy. So again, getting back to treatment, if you look at this picture of the virus on the left, the immune response on the right, early on, we're trying to target drugs to not kill the virus or disrupt the virus. And interestingly, the drug we were dealing with last night is one that creates what are called catastrophic mutations in the virus. So it does make mutations, but they're so horrific that the virus can't survive. Later on, when somebody's really sick, the drugs we're looking at are more for modulating the immune response. Now, if you look at treatment categories, there's sort of 2 main ones, drugs and immune-based. The drugs can be either brand new drugs that are being developed or repurposed drugs like hydroxychloroquine, which I'm sure you've all heard about, et cetera. And the immune-based treatments are things like antibodies, interferon, and inhibitors of certain cytokines that can lead to the inflammatory or the cytokine storm. Right now, you can see the list of drug treatment is not very big. Outside, for those outside the hospital, really the only thing is monoclonals, which are almost never used. And there's some data that they may be less effective against some of the variants, particularly the South African. The drug, for example, we looked at last night, however, looks like it might actually be effective here. So there is a light at the end of the tunnel, and there are tons of drugs out there under development, as are there tons of vaccines. In the hospital, there's really only about 3 drugs, remdesivir, dexamethasone, and tocilizumab. Those are the 3 drugs that would be used mainly. I somehow got 2 lines on my slides now that weren't there before, but anyway. Okay, let's focus on vaccines. The purpose of vaccines is to prevent infections. And the method is by stimulating the immune response and programming it. Again, looking at the virus, you can see here that spike, that all-important spike, that is the key target. So we're trying to produce antibodies that are going to block this attachment right here. Now, how do you prime the immune system? Marshall, is there any way of getting rid of those lines? Anyway, okay.
Not that I'm aware of, but I think they make it go faster. They're speed lines, Lionel.
So the target is the spike on the virus, and we have to expose the immune system to the virus, and that can be done directly or indirectly. Directly, you expose the immune system to the virus itself or to viral particles. Indirectly, with the Pfizer and Moderna vaccines, there's messenger RNA that goes into the human cell, and then you make the spike protein. Just in terms of a diagram, this is the older fashioned way. For example, the influenza virus, you give the virus that's been inactivated or killed. The new way with the messenger RNA is you give little bits of the genome suspended in this fat particle as an injection. And AstraZeneca and J&J use the genome inside of a different virus that's injected into your body. So this is what the Pfizer vaccine would look like, bit of RNA in the fat droplet. AstraZeneca would look like this with the genetic material in a virus. And the vaccine is given, the fat particle comes up to a cell in your body. You program this and you end up producing this spike on your own cell, and then your own immune system recognizes it. The way to measure vaccine efficacy is, does it prevent infection or acquisition of the virus? Does it prevent disease? And does it prevent transmission? Now, if we look longitudinally, this is what we expect from a vaccine. Here's the exposure to the virus. Ideally, you'd like the vaccine to prevent you from even acquiring it. That may not happen, so you acquire it and you become asymptomatic. Hopefully now the vaccine will prevent you from becoming ill. If you become ill, it'll prevent you from going to a hospital or the ICU or dying. So a vaccine may not prevent you. People can still get sick with a vaccine, but they may be far less sick than they would have been without the vaccine. So it's not like a light switch going on off. If we look at these different vaccines in Canada, Pfizer, Moderna, AstraZeneca, and Janssen J&J, which hasn't been released yet, there's two endpoints. One is the just overall symptomatic, the efficacy, did the person become symptomatic or not, and then severity. So Pfizer and Moderna are 95 and 95% against symptomatic, Oxford Zeneca 70%, and J&J 66. But for severity, the top three look very good. Now I put in this asterisk to illustrate just how crazy things are. Last night at 6 o'clock, I was on with the chair of infectious disease at Johns Hopkins and the editor of a journal talking about AstraZeneca, and we heard one thing. 10 o'clock that night, heard a different thing, and then this afternoon, and then an hour later, heard two other things. What happened was that there was a US study, and this is where my initial cautionary thing came in, a press release that there was a large US study that showed 79% efficacy. And that was wonderful news. Large study, and it included people over 65. The NIH then came out and said they want to see more data, and the company has now promised to produce published data in 48 hours. So you can see that anything we say today may not apply tomorrow, but so far, Pfizer and Moderna are excellent vaccines. Oxford AstraZeneca looks like a good vaccine, and hopefully in the elderly, it'll turn out to be a great vaccine also. Now, it's not fair really to compare one to the other. The AstraZeneca, for example, some of it was done in Brazil, where people are exposed to higher viral loads and variants. So it was being tested under conditions that were more difficult, for example, than the Pfizer and Moderna ones were. Now, the key responses to the vaccine, and we're getting close to the end, is you want a vaccine to produce antibodies, that's the vertical axis, and the horizontal axis is time. So you can see with the first vaccination, you're going to get an immune response. Then you get a second vaccination and you get an even higher immune response, and that could last on its own for a long time, or you may need annual boosters to keep it up, and that's great. The thing that's not talked about in the lay press at all, although it certainly is in the science communities, is memory. There's no point you knowing that you've got to worry about a particular enemy if you then forget about it. So immunologic memory is absolutely critical. It's one thing to be able to produce antibodies. You've got to be able to remember to recognize the person. and produce antibodies. And again, this is fascinating. The vaccine is given, the immune response turns on, and then in addition, if you look at the far right, to the antibodies, you get two groups of memory cells. At the top are T cells, and at the bottom are memory B cells. So you've got on the left-hand side all these naive T and B cells in your body. Somebody gives you the vaccine or you're exposed to an infection, and then you start to get a clonal expansion of each of these, and you hopefully end up with memory T cells circulating and memory B cells. So when the virus does come in 6 months or a year or 2 years later, they recognize it and they turn on the immune response to attack it. Now, it's one thing to have vaccines, another is vaccination, and we're all aware of what's happening. The vaccine has to be discovered, and it was. It's has to be produced and distributed, but it has to get into arms. The side effects locally, there's some pain and redness and swelling. I must say from the shots I've had, they were remarkably, they weren't much at all, just a bit of local discomfort. Some people can get systemic symptoms like fevers, chills, and then there's immediate allergic reactions like itching or hives or shortness of breath, and obviously anaphylaxis is what you'd worry about. But overall, again, these all appear to be safe and good vaccines. The key things that you've got to take away from this are that there are variants, and you have to worry about transmissibility, virulence, and evasion of immunity. The vaccines, and there has to be good rollout, and we've got to get rid of vaccine reticence through education. Opening up of the communities, we've got to be very careful about that, and of COVID fatigue. This is a quote I love from Will Rogers, who is an American humorist. Good judgment comes from experience, and a lot of that comes from bad judgment. Italy and a lot of Europe is seeing that now. They've opened up too fast, and now they're paying the price, and we have to be careful that we don't do that here. The absolutes that we have to be aware of is that we already have a surrogate for the vaccine. The masks work and distancing works. So we have to maintain public health measures, and we've got to vaccinate as fast as we can. There is a light at the end of the tunnel. Definitely, there is good news coming down the pike. So thank you very much, and stay safe and stay well.
Lionel, thank you very much.
You're welcome.
Your time is and knowledge is very much appreciated. Marshall, you're on questions.
And Lionel, thank you for paying attention for those 2 summers working at the pharmacy.
Yeah.
In the press, we read a lot about herd immunity. Why do I need to care about herd immunity if I've been vaccinated?
Can we go to the screen now so that people can see me?
Yep.
I'm not sure what you mean, Lionel.
Hang on. Okay. Okay. Yeah. So your question was herd immunity, Marshall?
Yeah, so I've had my shot. So why do I need to care if my neighbor has or hasn't had theirs?
I think I know your neighbors. No, they're two different questions. The herd immunity means, and that's an interesting point, having enough immunity in the community of people that you're in so that the virus just can't get a place to hook on. It's like, again, coming into a harbor with your boat and most of the slips are taken, you just can't find a place to dock. So if you've got all the slips taken up, that's great. You can't have boats you don't want coming in. So herd immunity refers to that, taking up all these sites so the virus can't hook up. The question is, what % of the population has to be protected? And it varies from disease to disease. The guess is that with COVID, it's probably about 75%. And then you would maintain herd immunity and the virus wouldn't be able to circulate well. But you can see the issues. There hasn't been a huge percent infected. And if the vaccine is, say, 85% effective, you've got to inoculate about 95% of the people. So we really need to get people immunized. But that's the idea of herd immunity. And probably the target figures for COVID is about 75%.
And what are they seeing and what are you seeing in terms of hesitancy for people to get the vaccine compared to normal vaccine hesitancy? Has that been studied at all?
Yeah, it's being looked at. You and I talked about this briefly the other night. It's astounding, some of these stuff. I had one patient, this woman, believe it or not, was a personal support worker who worked on the COVID ward of a Toronto hospital and taking care of COVID patients and refused to take the vaccine. And of course, she got COVID. That's how I ended up seeing her. And I said, why didn't you take the vaccine? And she said, well, she had concerns about it. When I asked her, I said, like what? Of course, she didn't know, had no concept of data or anything else. Just she'd heard her friends talking. And unfortunately, that's what happens. And it isn't always related to level of education. Some people think there's still people that it's a hoax and whatnot, but the main concern that people who are hesitant have is with safety and secondarily with efficacy. But I think I actually got one letter that I think some people are concerned that it'll get into your own DNA and you're going to become a virus or something. It's just crazy what some people think. But they are good vaccines. What the scientists did, I think, was just spectacular. And the other thing that's great is that with this new technology, the messenger RNA, it's like, instead of the old way, it's like having little cassettes. So if you've got a printer and you're tired of blue ink, you can say, okay, I'm going to take that out. I'll put in a cassette with orange ink. And then you say, all right, you know what? I really would like green ink. So you take the cassette out, put in the green ink cassette. And they can do that now. So they are actually setting up new messenger RNAs, that virus vaccines that can work against different modifications of the glycoprotein. And they can actually do that within about 8 weeks. The problem then is production. But the good news in all that is that what I think ultimately will happen is the pandemic will come to an end, hopefully, and it'll end up as an endemic situation. So yearly, we might have this problem, and we may well have to get an annual booster, and they might be, so you'll get, retweaked vaccines once a year, hopefully when you get your flu shot. But I mean, it's great. The vaccine technology really is wonderful. And they really do. I can't stress enough how much they look at safety. One of the other issues, though, I remember when I first got started in this years ago, you do a drug trial and we put out data that this drug was safe in 3,000 patients. And, oh, great. Okay, well, now we know it's safe. I mean, now nobody accepts that. They think, yeah, it's fine for 3,000 patients. But if you've got a really rare side effect and you may not see it until there's, one literally in a million, but if a drug is being given 1 billion times, and some of these blockbuster drugs are 1 billion every year, you're going to start seeing this. So there's what's called pharmacovigilance. They track all this. So as time goes on, there's the data from the initial studies, but then all this sort of real life data that's coming in as well. So,
and I think you talked about Israel the other night as being one of the leaders in that, just given the percentage of their population that's been inoculated.
Israel's been incredible in terms of their rollout, and I mean, it's pretty astounding. They use their military, and anybody who follows it, the Israeli military responds quickly. And they're very organized. And the other thing they did, though, is they made an arrangement with Pfizer to get back to them with study data. and the science in Israel is excellent, and they have fabulous medical scientists. And they have already, within a very short time, cranked out large studies, like with 1 million people in each study, on more safety and stuff. So, and that helps everybody. So that's been a real plus. I mean, obviously, it's a much smaller country. They don't have the logistic issues we do, but still, they've been great in that sense.
Yeah. Carol and Steve have sort of a similar question. When the vaccines were first announced, the lead time between, or the separation between first and second shot was roughly 21 days. Now in Ontario, we're looking at sort of 4 months. Can you comment on that? Are we at risk because of that extension? Are we better off because of that extension? And if I'm getting political, you can tell me to shut up and we can talk about sailing.
Yeah, just give me 10 minutes so I can stick my head in the oven. Yeah, personally, I think it's terrible. Every single physician scientist I know does not agree with it. There is not one scintilla of evidence to show data for 4 months. Now, that doesn't mean it won't happen, but the studies were not designed that way. Pfizer and Moderna set their studies up for 3 weeks and 4 weeks. And again, if you say follow the science, then follow the science. It's 3 weeks and 4 weeks. The WHO came out and said, well, it'll probably work 3 to 6 weeks after that. And that's probably true. But 4 months is a long shot. Where it starts to get really interesting, though, is if you look at the AstraZeneca data and start teasing that out. And they didn't have a uniform huge study like Pfizer and Moderna did. They had 4 trials stuck together with different doses. The group that seemed to do better in terms of immunity was the group that got their second shot 3 months or more later. So that's been the sort of wrench in all this. But certainly, I think most of my colleagues would say, and by colleagues, I'm talking about people on NACI and WHO advisors, et cetera, that sure, it doesn't have to be exactly 3 or 4 weeks, but once you go beyond that, nobody knows. And I do not know of a single person that supports the 4 months. I think that was purely political. Now, as I say, it may work and that would be great, but I don't agree with that.
Okay. I guess the next question gets to be a little bit mechanical. If I had my shot yesterday, how long, my first shot, roughly how long before I get some degree of immunity? And again, knowing that it's now been increased to 4, am I 100% the minute I've had my second shot? Or what's the follow-on period after the second shot before I'm 100%?
So I'll take the last question first because it's the easiest. Generally, after the second shot, your full efficacy would be probably about 2 weeks or beyond after the second shot. In terms of the first shot, I love saying this to sailing people, it depends, because that was always what was said to me when I asked a sailing question, it depends. So if you look, for example, at the Pfizer, after the first dose with Pfizer, if you looked the first week or so, the efficacy was only about 50%. But the figure that got out was, well, it was really 92%, but that was between the second and third week. But there weren't, but it has to be given by the third week. So there weren't data, after that. With AstraZeneca, the data that they have was after the first dose, if it's 15 days or more after the first dose, it's about 62% effective. If it's over 3 months after, it jumps to 82%. That's why you see that 70% response. So you should not consider yourself fully immunized after getting 1 shot. But after 2 shots, within a couple of weeks, you're fully immunized. But again, the concern there is, if there's really 3 groups. So in one group, you could have, let's say we're talking about 10 people, everyone's immunized, fully immunized, then just knock yourself out. You can wear no mask, hug and kiss, whatever. The other group, no one's immunized. So stay away and wear masks. The third group is 4 of the people are fully immunized, 6 aren't. Wear masks and stay apart. So 2 out of those 3 groups, you wear masks and stay apart. The concern is that just because you're protected with antibodies, there's a thing called mucosal antibody where you block the virus from actually hooking on to receptors in your nose, for example. You don't really get good mucosal antibodies with these vaccines. So you can still become a carrier. So you will not get sick, but you're carrying it. And if you cough or sneeze on somebody, they might then become infected with it. So that's where the concern is.
Right.
So that's why they're telling people, when people said, well, if I got the shots, why do I have to wear a mask? I'm not going to catch it. No, if you got both shots, you are protected, but you could still transmit the virus to someone else.
Right. Okay. And I guess there's sort of a follow-on to that question from Anita, asking if, are my symptoms somewhat diminished if I've been vaccinated? I can still get it, it sounds like, after the first shot, but presumably it's not going to be as dramatic as if I had no vaccine at all. Is that a fair statement?
That's probably fair. I mean, it's certainly fair for if you got both shots, and it's probably fair depending on the time point for a first shot. Yep.
Okay.
Now, the other thing to keep in mind is, and we tell patients this all the time, look, talk to a patient and they're in an absolute panic that, they got COVID and they have images of ventilators and everything. We say, look, less than 10%, 90% of the patients stay out of the hospital. They do well. And of those, some of them have a bit of a tough time, but generally people are doing well. So, and then they right away start to, the worry level goes from, 12 out of 10 to, a 7 out of 10 or whatever. But so, and I've had a number of patients, and some in their 60s, when I've asked them, they said it was nothing. They've had colds and flu that were worse. And of course, we've had the opposite as well. But so the vaccine can protect you from becoming symptomatic, but it would be, whatever percent less than it might have been.
Mhm.
But even with the infection in the unprotected patients, sometimes it's mild. And as we know, a lot of them are asymptomatic.
Yeah.
It's
So-
really a small group that we're trying to protect. Those with high risk situations, the elderly, et cetera.
Mhm. We're hearing stories of people who have had the disease and X number of months after show no signs of antibodies anymore. How are we going to know in a year's time if we're going to need a booster? Are we going to be testing people who have had both shots to figure that out? Do you already know? Is that known information, or is that still TBD?
That's a good question. Can you just ask me again the, oh, right, you're saying people who got their shots, but
No, I've had the disease.
Right.
I'm now fine, but I've been tested and the antibodies I had a month ago are now gone.
This is someone who had the disease. Okay, right. Yeah, that's a very good question. So again, it depends. Part of the problem with a lot of this is that the level of humoral immunity, like antibody level, does not necessarily correlate with protection. So you can find someone that actually is protected, but you don't find antibody levels, but they'll respond. And most tests won't start to look at their T cell subsets. So it'd be nice to have antibody around, but the fact that you may not find antibody doesn't necessarily mean you won't be protected. Now, can you say to somebody, look, you got COVID and you got better by March 1st? We just simply do. In fact, I got an email the other day from Spain, somebody asking me this, exactly that question. And I basically wrote back and said, I don't know, and there are no data. We really don't know. Normally for neutralizing antibodies, it's several months. But again, it could vary. Was that person elderly and less likely to produce an immune response? Were they on immunosuppressives? But generally, the idea is you'll be protected. Now, the other problem with all this, too, is that you may have gotten COVID, but what if a variant comes along that has mutated. So it doesn't work. That's not good. So
Yeah.
that's the setting where we might down the line be looking at boosters on an annual basis.
And so that booster will get tweaked slightly based on how the
Yeah,
mutations have taken hold. Yeah.
exactly.
Given how long I could see the RNA strand is inside the virus, is that what it was, an RNA
Yeah.
strand? You said?
30,000 bases.
Right. So given its length, is there any limit to the number of mutations or variations we can see in this?
In any
booster?
one?
Well, in how many COVID variants are you anticipating? 7,000,
I
12?
actually read something a few months ago that said there have been 12,000 documented mutations that have occurred. Well, you can imagine, just like that picture of the baby with the blocks. If you say, okay, never mind a baby, you take somebody that you think is reasonably smart and said, here's 4 blocks. I want you to put them in a certain order 10,000 trillion times. They're going to make mistakes.
Yep.
And 12,000 mistakes out of 10,000 trillion is actually nothing. So as I say, mistakes happen constantly, but most of them are just forget it, forget it, forget it, forget it, until you get suddenly one that, uh-oh, this one affected the fingers on the hook. This isn't good.
Mm-hmm. Interesting. I'm taking an ACE inhibitor for my blood pressure. Is that making me more susceptible or less susceptible to COVID?
Actually, that in many ways is a fabulous question. And it was a question that came up a lot early on. The answer is stay on it. Stay on the drug. I mean, that was debated a
It was
lot.
Graham's good question, by the way. So.
It was debated a lot in cardiology
Yeah,
circles
good.
A year ago. But basically the decision is if you're on an ACE inhibitor and it controls your pressure well, stay on it.
Question from Patrice. What are your thoughts on the reported increased risk of CVST as a rare side effect of the AstraZeneca?
What is CVST?
It's a transmission on a Honda, as far as I know.
Oh, cavernous sinus thrombosis?
That must be it. That was the first thing that came to my mind.
Yeah. Yeah. Well, if you got a Honda, you'll be fine. Oh, it's cavernous sinus thrombosis. I've never heard it referred to that way. So again, that illustrates exactly what we're talking about, how things. So right now it's 8:20. So everything I say at 8:20 may not apply at 9:20. Okay, just so we're clear. The concern is clotting. And when you get clots, you can get them in the veins and you can get them in the arteries, and that's not a good thing. One of the main problems with actual COVID is clotting, and that's become a major issue, and that leads to heart attacks, strokes, pulmonary emboli, et cetera, et cetera. Then there started to be some reports from Europe of clotting. And so they halted, as they should, like the data monitoring board might say, okay, we're seeing a signal, hold the trial. And we do that fairly frequently. And they'll stop and look at it and say, no, it's okay. So they actually cleared it for general clots. Then I think it was last week on a Wednesday night, someone had asked, I got an email giving a pregnant woman the vaccine who was in a high-risk situation. And I'd sort of made my decision, is 11 o'clock on a Wednesday night. I'm about to type it in. And I came across this data from Germany that said that day, there's a higher incidence of cavernous sinus thrombosis in young women, higher than the general population. So I discard, I didn't send that email, waited till the next day when the data had changed. And now the EUA, which is the European counterpart of the FDA, has cleared, they said, no, there doesn't appear to be a clotting issue. I can tell you whatever clotting issue there is with the vaccine is still far less than with the disease. But yeah, it was an interesting question. And they did look at it very closely, but cavernous sinus thrombosis can be particularly nasty. It's when you get clots in the vessels that, anyway, it's bad.
You mentioned pregnant women. Should pregnant women get the vaccine? Should they avoid it? Has that been studied? Is that known?
Yeah, it depends. So it has not been studied. There are no robust data on pregnant women. It hasn't been looked at with any amount of data. The feeling is generally, some people feel that pregnancy in later stages puts you at higher risk. So I think it's not a one size fits all, like yes, no. So for example, this woman I was asked about, she's in her mid 30s. She's pregnant, 6 months pregnant, but she's a teacher. So she was in a high risk situation with young kids. So if she was her twin sister just, stayed at home or went to the park or, whatever, I would have probably said no. But for this woman, because she's in a high risk situation, we said yes. So generally the feeling is it's probably safe in breastfeeding and pregnant women, but I don't think, if you think you don't need it and you're otherwise okay, I would say hold on. It's always better, I think, in pregnancy, if you absolutely don't need it, to hold off on any biologics. But if you do need it and you're at risk, I think it's reasonable.
Yeah. I might have asked this question before, but if I've had COVID, I'm now better. I am susceptible, I'm assuming, to the variants. I'm not immune from getting any of the, I'm not immune from catching any of the variants.
Yeah, it'll depend on the variant. If it's UK variant, you're probably immune. I don't have a good answer for Brazil or South Africa. And I certainly don't have an answer for what might come down the pike in 2 months. But again, this happens with influenza every year. There's what's called antigenic shift and drift, and there are groups literally around the world that keep tracking the virus, looking for these changes. And if there's a major change, like in the hook or whatever, they'll immediately let the CDC or whatever know, and they'll say, okay, switch to vaccine X this year, we've got to make a new one or tweak it. And that's, I think, what will likely happen here as well.
Yeah.
So it depends on the variant. You may well have protection, and right now it looks like you probably would, but who knows what'll come.
So if I've had the vaccine and I'm tested for antibodies, do I show that I have antibodies? Does it work the way that the old vaccines do?
Yeah. And that's one of the things they obviously would look at is there a response? Do you produce antibodies? And then in the laboratory, like this is long before they would go to even the clinical trial stage, is they would take the antibodies and see, do they actually block the virus from attaching to cells and stuff. So this is looked at incredibly carefully. Again, just to give you an example, with this drug last night we were looking at, now it's a drug treatment, but there's been a ton of time and money spent just trying to decide on the dose. And even within that, aside from any safety issues, whatever, we're measuring the rate of mutations occurring in the virus, the viral load, viral attachment, all kinds of stuff like that. So they certainly do that. But for the average person, once the average person gets a shot, they are not going to check to see that you got antibodies.
Right. Okay. Okay. But if I have had the shot and for whatever reason I am tested and I had Astra the first time, would they give me Astra again, or would I opt or be recommended to take a different vaccine?
Yeah, don't switch. If you got an RNA vaccine like Pfizer or Moderna, stay with the RNA vaccine. Your second shot should be a Pfizer or Moderna. Do not cross over. And the other way too, if your first shot was AstraZeneca, do not go and get Pfizer. So, you stick with whoever you took to the dance.
Yep, good, okay. Question from Karen. If I have a history of anaphylaxis, is there one vaccine I should take over the other?
Yeah, good question. It depends what's the anaphylaxis to.
Yeah, and not specified, so.
Yeah. So
is that
if
a
it's,
question
I
for
mean,
your
it's a good
doctor?
question though. If it's anaphylaxis to bee stings or something like that, or insect vectors, whatever, no, that's not a contraindication. So what are considered absolute contraindications would be if you got the vaccine and had anaphylaxis, that's a contraindication. Or if you happen to know that you have hypersensitivity to
Well, let's say egg, because egg is commonly used and
yeah,
egg,
egg's not in this. It's polyethylene glycol. I don't think too many people know if they're allergic to polyethylene glycol. So I think if you have a history of allergies and particularly anaphylaxis, you should sit down with your doctor and go over it. But we've been asked this, if it's bee stings or something like that, or penicillin, that does not mean you can get the vaccine.
right, okay, good, good. All right, we just have one question here. Oh, here's an interesting question. How would an antiviral during a shingles outbreak affect the COVID antibody? So I've got an antiviral I'm taking during a shingles outbreak.
So the person
Any relationship with all those?
So the person got
Are we
shingles.
getting into
This is Joe Smith gets shingles, and he's now taking drugs for the shingles. Should he get the vaccine?
yes.
No.
Okay.
And for a variety of reasons, probably the simplest is that you won't be able to sort out side effects from the vaccine, because if he's taking the shingles and he's taking acyclovir and he's getting the shot and now he starts throwing up or passing out, what's causing it? So
Right.
there's just that simple logistics thing. The other thing is it's likely not going to interfere with the immune response. It would be different if you're talking about the shingles vaccine. You should not get another vaccine within 2 weeks of the COVID vaccine, either way. But for the disease itself, I would say to somebody, look, if you're right in the throes of shingles, that's too bad. But take the valacyclovir, and then when you settle down, get the shot.
Take some time. Okay. This is a sailing club, so I've got the standard sailing question. Given the distribution of vaccine, what is the probability of us having much of a racing season this summer? And again, if that's a put your head in the oven question, we can talk about the Blue Jays or something.
Can you read me a list of who's on the line before I answer? No, I mean, that's obviously the question we all are wondering about. And let me just put in a plug here. I think Ontario Sailing has done a great job, and the sailing office with Tommy Warden, they've really done a great job. They've put a lot of effort into this last year, and I see what they're doing this year. They are really being careful. And if you're going to err, I think you should err on the side of being overly conservative, personally. So if you're going to make a mistake, you want to make a mistake in the direction of the least harm and the most good to the most people. So as of now, there is no answer. We simply don't know. But I think what I know that Ontario Sailing and the sailing office will track this very closely. But let me explain this, because this thing has come up about like 100 sailors in a regatta, blah, blah, blah. So if you're 100 sailors in lasers or fins or 2.4s, that's okay. It's not great when you're rigging your boats and you're close by, but once you're out racing, you're okay. So if you said 100 sailors in lasers, that is completely different than having, say, 33 sharks with 3 people in each boat, because again, it's a numbers game. So it depends how much virus you're exposed to and for how long. And I think some people have this image of sailing. Well, the racers don't, but that sailing, you're on a 200-foot yacht and you're at one end, your friend's at the other, blah, blah, blah. That's not what happens in a J105 or a Shark when there's, 15 knot winds and you're heeled over and everybody's falling into each other. They're yelling, whatever. On our boat, we never yell, but some boats yell. And if you wanted to let's set up a model to spread COVID, you would say, you know what, let's put 4 or 5 people in a boat and have them race and heel the boat. So if that's the setting, we should not have racing then. And that would be simply common sense. So it really is going to depend. I think if you could race with if you and your crew were fully vaccinated, that's different.
Mhm.
If you were racing with family members, then you're in a bubble, that's different, that's okay. But, until we're fully vaccinated, you and I shouldn't get in a boat together without masks and distancing. So it's really going to have to be something that's called on a week by week basis. Everybody wants to get out and race, I know that, but we'll just have to wait and see.
And it's going to be dependent on vaccine delivery fundamentally, right?
It'll depend. It's going to depend on a variety of things. I mean, that closure code. So it'll depend on the percent positive testing, the R naught, the variants, how many people are vaccinated. I guess we could have a regatta instead of having a Royal. We could have the those who are vaccinated regatta. But yeah, it's going to be tough.
Bring your vaccine passport when you come. That's your admission ticket. No beer tickets, just vaccine passport tickets.
Yeah.
Okay, Margaret, those are all the questions. So I will pass it back to you.
Thank you, Marshall. Thank you mostly, Lionel, for your knowledge and expertise. Thank you for everybody coming to attend the talk tonight. Your time is appreciated, and Lionel, thank you.
Thank you very much.
Your time is very much appreciated.
Thanks a lot, guys. Take care. Bye-bye.
Bye-bye.